Good morning, everyone. I think we can start. Welcome to this webinar organized by the OASES Project Consortium. Let me share my screen. Yeah. Very glad to see many participants. My name is Stella Lanzi, and I am project manager at AGENAS, the Italian National Agency for Regional Healthcare Services, and that is the coordinator of the OASES Project Consortium. Please allow me, before starting, to provide a few technical indications. First of all, the webinar is being recorded already, and the recording will be made available on the OASES project website shortly. Secondly, please keep your microphones muted during the webinar, and if there is any question, which is more than welcome, you would like to ask to our speakers, please write it in the chat box. We hope to be able to answer to all of them throughout the webinar. We have a dedicated question and answer session at the end. Before leaving the floor to our speakers, I would like to say a few words about OASES. OASES is a project focusing on medical deserts, co-funded by the Health Programme of the European Union. It started in March 2021, and it's currently approaching its end, which is in February, next month. The project has aimed at strengthening the capacity of public health authorities to reform their health systems and address the key issues to successfully deal with the challenges posed by medical deserts. Here is a map showing the countries involved in the project. And that is 7 European countries. So we have Cyprus, Finland, France, Hungary, Italy, Moldova, and Romania. So this is the OASES Consortium, and these are the countries we have focused our work on in the past 3 years. And here are, in brief, the activities we have carried out within the OASES project. First of all, literature review. That is an analysis of medical desertification. A literature review was performed at the EU level, analyzing the possible antecedents, causes, factors driving desertification. An inventory of potential solutions has been analyzed and proposed to the participating countries that are the executors of the pilot studies to support their consensus building exercise. Then we have carried out the pilot studies, which will be presented today at least in terms of preliminary results, because the actual report of the pilot studies is undergoing a review by the European Commission, but we expect it to be finalized, approved shortly, well, maybe next month. So we will be able, ideally, to share it on our website very soon. And those pilot studies were articulated in 2 parts: a measurement part. So a measurement methodology was articulated in different maturity levels for measuring medical deserts. And based on the data sets that were available in the pilot sites that were identified in 7 participating countries, different parameters and measurements have been implemented. So we made research to understand what kind of data sets were available, relevant data sets were available in the 7 European participating countries. And then we developed a consequent measurement methodology that could be applied. And then the consensus building exercise. In each of the 7 pilot sites, consensus building exercise took place, consisting of several rounds of online disseminated questionnaires, applying a Delphi modified methodology, so multiple surveys giving a tighter focus, a progressively tighter focus on the issues that were discussed, and virtual or in-person meetings per country with the relevant stakeholders that were identified in each country, with the goal of reaching consensus on a definition of medical desert, the dimensions of medical deserts, the areas considered to be medical deserts, the causes of medical desertification, existing policies to address medical deserts, and possible mitigating actions. So those pilot studies were a combination of involving the stakeholders, the relevant stakeholders in the participating countries in the exercise, and carrying out measurements in those countries, in those pilot sites, and to understand the dimensions, the actual dimensions of medical deserts. And now a sustainability analysis is being carried out within the project, a sustainability analysis of the initiatives that were identified to mitigate medical deserts through these pilot studies. So these pilot studies, as you will see in a while, have led to the identification of mitigation strategies in the countries involved. And now we are better analyzing the conditions for their sustainability. So this was a brief introduction to the project. Thank you very much. We will now move to the core of today's webinar. So I give the floor to Monica Brinzak from the Babes Bolyai University of Bucharest, that is the leader of the work package 6 of the project, who will provide an overview of the preliminary results of the pilot studies carried out within the framework of the project. Those, as I said, are currently being reviewed by the European Commission and have not been published yet. So this is a first overview, which will be followed in the coming weeks by the publishing of the official report. The links you can see here on screen will also be provided in the chat box, the link to the website, and an evaluation survey will be provided at the end of this webinar. So have a look at the chat box. Thank you very much. And Monica, the floor is yours.
Thank you so much, Stella. I will now share my screen. Okay, lovely. Thank you so much. So as Stella kindly already mentioned, my name is Monica Brânzac. I come from Babes Bolyai University in Cluj-Napoca, Romania, and I will discuss about the results of the OASES pilot studies, work that we've done for, I want to say, the previous 2 years. So a lot of work has been put into it, and I want to take this moment to thank all our partners, because the work that has been put into this has been immense, and the dedication and the patience, I honestly appreciate it, and I congratulate each of our partners for their work. And of course, I want to thank Stella for her coordination, and then Marta and her team for preparing the OASES webinars and our communications in general, and of course, Corinne for kindly joining us. So the topics that I want to talk about today is a general overview of the pilot studies. Then we'll go over each country in detail, and then we will discuss about the recommendations to mitigate medical deserts and the conclusions. Of course, given the time limitation, I will not be able to go in great detail, considering that our initial final report is of 200 pages, so the level of detail that is in the report I will not be able to put here into this presentation, but once we will have the approved final version of the report, I invite you to check our website and read it in greater detail. As for the pilot studies, so we organized the pilot studies in the 7 OASES countries that Stella already mentioned, and that you can see here as well. So Cyprus, Finland, France, Hungary, Italy, Republic of Moldova, and Romania. and had the objectives to create an overview of medical deserts in the 7 countries involved in the project, to assess and characterize medical deserts in the 7 countries at national or regional level, and the mitigation strategies in place or planned. Then it aimed to facilitate consensus regarding mitigation strategies targeting medical deserts among stakeholders in each of the 7 countries, and then to provide evidence-based recommendations to mitigate medical deserts in the 7 countries in the consortium. As Stella already mentioned, the consensus building exercise followed Delphi Online methodologies with several rounds of surveys, of questionnaires, and then qualitative meeting. We had so the consensus building exercise was designed on the particularities of each country. We had individual meetings, bilateral meetings with each country from the project to decide what is the best approach for the country itself, and to make sure that our consensus building is reflecting the reality of that country and does not provide a generalized European view. So in Cyprus, Finland, Hungary, Italy, and Moldova, we had a national consensus building exercise, while in France it was at the national level, but focusing on the BFC region. And then in Romania, we had focused on the northwest region of the country. So you see, we have a great diversity here. And I will go straight in Cyprus. And before going into details about the Cypriotic pilot study, I want to make sure that if you have any kind of questions, or maybe if something is unclear while I'm presenting, please make sure to write your question, or to make sure that you mention what is unclear in the chat for me to be able to answer it at the end of the presentation. Thank you. Now, going into details on the pilot study that we had on Cyprus. In Cyprus, we had 2 survey rounds and then 1 qualitative consensus meeting. And if you want to know what determined the number of rounds in a survey, it was reaching or not reaching the consensus that we have established. So before starting the pilot studies, we have established that we will consider consensus an agreement rate in the survey of 80%. So if you did not reach 80% on those questions, you had another round. And if in the second round you did not reach consensus, you had a second round, and so on until you reached consensus. And then after those rounds, we've analyzed all the responses, and then we had a qualitative meeting based on those answers. And of course, each survey round fed the next survey round. So based on the answers that we had in the first round, we designed the questions from the second round, and so on. So in Cyprus, we had 2 survey rounds and 1 qualitative consensus meeting with a total of 22 participants in the first round of the questionnaire and 9 participants in the second questionnaire. And in the case of Cyprus, the medical deserts often refer to areas with limited access to specialized medical care and emergency service. In such contexts, stakeholders have identified the emergency department particularly concerning accidents and trauma as a fitting example of medical desert. And the implementation of the general healthcare system in Cyprus, also named as GESI, represents a significant effort to address healthcare disparities and to mitigate the existence of medical deserts in the country. The GESI system, the GESI system is designed to provide universal health coverage, ensuring that all legal residents of Cyprus have access to essential healthcare service regarding of their geographical location. And these potential strategies include telehealth, community health programs, and healthcare professional training. And another mention that I want to make is that due to the cold season, my voice might disappear at some point, so please have a bit of patience with me. Now, the exploration of medical deserts in Cyprus have revealed the diverse challenges in healthcare access, ranging from overcrowded emergency departments in urban areas to the lack of services in rural villages. Those valuable lessons have been identified for healthcare providers, policymakers, and stakeholders. And the key takeaways that include the importance of recognizing varied changes, promoting public-private collaboration, optimizing resource allocation through specialization, and implementing alternative care access points, prioritizing pediatric care, enhancing health data co-organization, and developing innovative solutions for rural areas, and addressing, of course, financial barriers and emphasizing collaborative efforts among government agencies, healthcare providers, and users. And these lessons should guide future efforts to improve access to specialized medical care and emergency services in the country. And of course, addressing the medical services in Cyprus, it requires a multifaceted approach that considers both the immediate challenges and the possible solutions. The awareness that we got from the pilot studies and the lessons that can be learned for comparing the national cases should serve as the foundation for future initiatives aimed at ensuring equitable and comprehensive healthcare services for all. These are a few of the details from Cyprus, and now we'll go to Finland. In Finland, we had 3 rounds of surveys with one qualitative consensus meeting. We had 8 experts that participate in the first survey and 7 in the second and third survey and 5 in the final meeting. And according to them, the factors that led to medical deserts were the aging population and its consequences to increasing the service needs. And in addition to aging population, the issues that increased the problematic of medical deserts is the mental health issues of the young people. And another factor was the difficulty in recruiting professionals in small municipalities. And some of the issues that were discussed in the meetings was the barriers that prevented employment in the remote areas that were stemming from the matters of family and life situation, which makes working in bigger centers and cities more desirable. And we have found this across more countries and most of the OASES countries, that people do not want work in areas in which they don't have a lot of leisure activities, don't have good schools, they don't have a lot of opportunities and options. Rural areas that are more secluded and that have less options are less desirable than bigger cities where the diversity is bigger. And in the other hand, if the employment actions were ample and if there were enough social and health sectors employment areas, the workplaces will inevitably go without and contributing in this way to the medical deserts in bigger cities and within cities, this leading to a weakening the organization of work and working condition and further worsening the current situation. And of course, the medical desert definition that was created in Finland has, of course, its strength, but also its weaknesses. And it was the first exercise of this kind in Finland and in the majority of the countries. So we are basically laying the groundwork for the thematic of medical deserts. At national level in Finland, some of the proposed mitigation methodology and solutions were a national and organization level, starting with the national level to secure sufficient funding for the training of health and social care professionals, streamlining labor immigration and utilizing it more than currently, and of course going then to a more flexible staffing levels. And here we're discussing about the ratio between the staff and the patients. At an organizational level, we are discussing about focusing the work of professionals on tasks that match their education and their skills, and reconsidering the division of work between professionals and job descriptions. And of course, we're discussing about promoting service availability within digital, take-home, and mobile services. So you see that we have this discussion of flexibility, which is very important to Finland and Finnish people. And now, going directly into France, we are discussing about France is, I want to preface everything by saying that France is the country that has the medical desert topic advanced. They led the discussion on medical deserts. They were the first ones to have a definition of medical deserts, and they've created indicators that were groundbreaking, and that helped us a lot in the process of our project, in all the processes. So I want to thank them for that. So the pilot study in France was a bit different, a bit typical, because they had already so much work done on the medical desert topic, so it was a bit redundant for them to do the same process for us, and we've taken a different approach. Basically, for them, they've done an immense lit review. They looked at policies, they looked at literature, they looked at everything that has been done in France regarding medical deserts, including mitigation strategies. And then for the BFC region, they've done interviews with stakeholders to make sure that they're going a bit into depth, see what can be done and what should be done and how we can help. So in France, they have they've started and they've led the medical desert discussion because they were the ones that faced quite big problems on the certification themselves. So they've had to do something, or they were obliged to do something about that, to act upon it. And in France, they've had the absence of an explicit global project for primary care, but also the absence of a populational-based and territorial organization of ambulatory care. So we have these first two levels that were kind of hit. And in order to tackle medical desertification and to improve access to care, the public authorities, and here I'm talking about state, national health insurance, and the local authorities, have gradually deployed several responses aimed at doctors, future doctors, and other primary care professionals. And these solutions take place over different time frames and can be grouped into 4 types of responses to which we are discussing and in a greater detail and in a non-exhaustive manner. And we are discussing here about education, about increasing the number of GPs practicing, about targeting the areas for policy support by and improving the geographical distribution of health workers, attracting and recruiting them in the medically underserved areas, and to alleviate the GP's workload and to recognize the primary healthcare delivery. And this by improving working conditions, scope and role of professionals, e-health, and territorial organization. And and at the local level, we are discussing about the persistent change in attracting and retaining physicians, particularly GP practitioners, the challenges of healthcare delivery imbalances, specifically between the supply and demand for healthcare services, and local policies. And I will discuss now about the targeted healthcare profession, which most of the intervention and policies focus on them and primarily on the GPs, but other healthcare professions are also considered, notably allied healthcare professions. And here I'm referring to nurses, psychotherapists, and so on. And while the flow of the foreign trained doctors is relatively small overall in France, they are not so modest in certain areas of France and rural fringes, where foreign doctors are most likely to set up practice than their French trained counterparts. And this is mainly because it's easier for them to go where there are no professionals and they are happily received and well received. And this policy consists both in supporting French medical students, helping foreign trained physicians outside of EU to get authorization from country councils of physicians and to attracting the EU foreign trained physician. Another mitigation proposal would be the context and the issue that should be taken into account but cannot be directly addressed, or the difficulty by health policies at local level. And here I'm discussing about the geographical distance between initial medical education training and some student, rural living areas, or internship position. Of course, and we have to consider the stigma regarding certain areas, usually remote, rural remote, and that could be that could be entertained by the faculty or medicine members, and faculty internal policy that disregard the internal position in the rural areas that end with the vacancy rural internship position. But of course, we have to think about the attractiveness of the living areas in terms of amenities and conditions. And here we also have to include the environmental amenities like transportation, service, so on. But also demographic, occupation, and employment that are key determinants for physician location decision and mostly of concern and of the territory deployment policy and the regional and national level much more than the health and healthcare policy at the local level. So we are also discussing about collaboration. We are discussing, of course, about the health sector, but we have to take in consideration that we have to collaborate in order to attract those people where they are most needed. Then we are discussing about the main determinants of the attraction or retention that are taken into account by the intervention or policy, or on which the intervention is grounded on. And local authority, regional health agency, county council of physicians, and regional union of healthcare professionals mainly focus on the following determinants of location, attraction, and retention: the territorial origin, the initial education experience and living conditions, building professional personal projects as a follow-up of the education and the future professional and personal project of that student, the practice location, and if the student has an actual preference on that practice. Another result is that the new trends of the local policy or measures to attract and retain new healthcare professionals are depending on when that occurred, before or after the initial education, the category, type of intervention, the expected time frame of the impact, and the evaluation of the impact, or at least the follow-up of its implementation. Let's go to Hungary, where Hungary had two survey rounds and one qualitative consensus meeting. And as for Hungary, the definition for medical deserts is areas where the access to healthcare services it's limited based on a variety of factors such as the age of the general practitioner, shortage of the human resource, unequal access to care, the number of vacant primary care practices, reduced office hours and the replaced practices, the distance to the healthcare provider, the low number of GP clusters, and the disadvantaged status of the settlements. So once again, we are discussing about GPs because most of the OASES countries focus on GPs, and we are talking about the disadvantaged status of the settlements. So we are talking about these areas that are disregarded and that are seen with a low value, and people do not want and do not wish to attach themselves to that places, even though those are the places that would benefit the most from their service. And in once again, apologies. And in the Hungarian pilot study, we have worked on several statistic databases, and in some cases, the discrepancies occurred between the content in different databases, which of course happens to each and every country. But this draws the attention to the significance of data quality and the need for triangulation between different datasets. And as an indicator for that, there were mixed results between where medical deserts can be found in Hungary. The consensus in the qualitative meeting was that the Borsod, Ayugin, Zeplejin, sorry for the Hungarian colleagues if I completely butchered the name of the region, was one of the main medical desert areas in Hungary, but when we looked at the statistical data, that was not confirmed. So we can identify inequalities and anomalies in certain respects, but we can only speak about relative difficulties in accessing primary healthcare services, and closely related deserted areas cannot be depicted. And through the vacant and permanently vacant practices that are monitored regularly, and the stakeholders that are mentioning the number of vacant practices as an indicator to identify the medical deserts, in the vacant practices, the primary healthcare services are carried out by replacements. And of course, we have to talk about the sustainability of having replacements. And besides that, if we take that in and if we take into account the number of locally registered patients in the primary healthcare practices, the number of primary doctors per 10,000 locally registered patients shows us an unequal distribution of them by contrast to the vacant practices. So we have taken into consideration multiple indicators when we are looking at the data. It is not enough to look at what practices are not vacant. We have to look also how many people are being served in that area. And we are talking about the high average age and the high share of primary healthcare doctors aged 65 and older that can be detected as a high risk for the availability of appropriate primary care services in the near future. And we have concluded that more actions or programs are implemented in order to create GPs clusters, so establishing them can be regarded as the main mitigation strategies from the last few years in Hungary. And also, an additional thing that we noted is that stakeholders mainly follow professional information channels as main sources of professional information, including the issue of medical deserts, and several mitigation strategies, steps, and policy actions that were carried out recently have not been mentioned anywhere in those channels. And thus, they have not been mentioned in our questionnaires. And we found that based on the lack of the information, they did not even have the knowledge about those actions. And then the new system of territorial collegial professional leaders can sort this problem out by making the communication better at the local level. And collegial professional leaders at county level have already established better working communication channels towards policymakers that can support handling the challenges of medical desertification. However, the establishment of effective communication towards practicing doctor is not yet completed. So we also have to discuss about communication. Now, how we communicate is very important. And this voice right now, it's not best for communication right now. And then the stakeholders emphasize that the need for an extension of primary care, including the recruitment of new specialized within an extended competence of practice in primary health practices. And this could provide a new direction for primary health care that would significantly improve the quality, the efficiency and quality of care. And of course, solving the human resource problems and improving the quality and the efficiency of primary care are difficult tasks for both the policymakers and the stakeholders. But the number of initiatives, programs, and the financial subsidies and regulations were implemented with the aim to handle those problems. By all means, it seemed to us that based on the pilot results, the time is needed for those actions to succeed and make oases in the deserts. Now I will discuss about Italy that had 3 surveys and 1 qualitative consensus meeting. And as the definition of medical deserts, they have established that medical deserts are contexts in which there are critical issues in the dialect between healthcare needs, demand, and supply. And they have, based on the results of the pilot study, they have created this lovely table where we have the connection between territory, population, and availability, quality, and accessibility. And we see that between territory, the supply in a given area, and availability, you have presence. Are there health services, professionals? What are their characteristics? And then if we're going to the right, in the cell between territory and quality, we are talking about performance. Do we have the desired quality of those services? Do people trust the quality of the services enough to access them, or would they rather go into another area leading to health tourism? Then we're discussing about accessibility and territory, and we have the usability. Are they easy to reach? Are they easy to use for a wide range of patients? Then, if we're going lower to the population and availability, we are talking about coverage. Are we covering all the population in that area? For example, we can talk about certain socio-cultural dimension. We are talking about, for example, we can talk about certain religions that cannot, in which women are not permitted to see male doctors, or language barriers. Then we are talking about the population inequality, and we have protection. Those services are ensuring health protection for the resident population, or do we need to provide more quality? And then we have about, we're talking about accessibility and population, and we have equity in healthcare, which is so important. And here we have to ask ourselves, those services, do they guarantee equality in access to treatment and outcomes? And now, in Italy, similarly to other OASES countries, we have identified a lack of adequate policies as the main perceived cause of medical desertification. And relevant aspects of medical deserts are either at a national, regional, or local level. For example, at the national level, we can discuss about the allocation criteria for healthcare funding among regions that might also consider the mapping of medical deserts. At the regional level, we're discussing about strengthening healthcare networks, and the local level, telemedicine as a mitigation tool. As from the point of view of the analysis, we have to think, and it is desirable that in the future, the aspects that are characterizing context should be taken into account in the assessment of medical deserts and in the construction of the indicators. Those elements to be understood as interacting factors that could mitigate or exacerbate the condition of healthcare deserts refer in particular to the urban setting, and here we're discussing about urban-rural context, areas undergoing repopulation or depopulation, and so on. And the orographic, meaning the presence of natural barriers. We're discussing about mountains and so on. And then the regulatory and the organizational aspects, such as the residence requirement for that area and for those for access to healthcare services, the presence of infrastructure and means of transportation, the availability, and here I'm referring to the availability and quality of the road network, railway stations, taxis, and etc. Because if I'm not feeling well and I have to travel 30 minutes or 60 minutes by car or by bus, or I have to exchange trains to get to my local hospital or to my GP office, most likely I will postpone my visit as much as possible because of the difficulty. Or another thing that we have encountered is because the organization, the orographic the orographic factors were so big, they they refused to use healthcare services because it was impossible for them to do that comfortably. And then we are thinking of the qualifying environmental characteristics. And here I want to mention the green areas, the level of pollution, and so on, the welfare measures, the presence of social capital, and here we're referring to associations, voluntary work, the socio-demographic and economic labor characteristics, and of course, the population state of health, which is either measured or perceived. And more generally, the challenges that we face for the coming years is to define a set of measures that can be calculated by all European countries, applicable in different countries, and sustainable at both national and local levels in order to develop common policies and intervention plans. And of course, the concept of medical deserts appears to be a synthesis of a number of issues related to availability, quality, and accessibility of healthcare services in a given territory. And the phenomenon that we have here calls for an effort of systematization. And as far as the mitigation actions are concerned, there seems to be a need for policies that are dealing with medical desertification in a more targeted and visible way. And in this way, some of the ongoing policies and in this way, some of the ongoing policy development appears to be promising and worth being closely monitored and assessed. And now going into Republic of Moldova, where we had 2 surveys and 1 qualitative consensus meeting with actors starting from the Ministry of Health, the National Health Insurance House, professional organizations, and so on. And as for the results, the definition that they've agreed upon is that medical desert is a distinct geographical area where there is no health worker available to offer health and care services to the population itself. And in their case, all participants acknowledged the existence of medical deserts in their country, once again, especially in the rural areas. However, the current statistical data and indicators were deemed insufficient to identify specific geographical areas as medical deserts. So once again, we are returning to the quality of data. Do we have enough data to carry on in-depth analysis? Or should we work more on the data that we are collecting and what are we making with that data? And of course, despite analyzing the various indicator options, no single set gained enough confidence to be confirmed as a medical desert from a statistical point of view. And of course, the existing indicators such as the overall population and healthcare infrastructure were considered weak as they did not account for distance and time factors. And an additional set of indicators that include the travel distance and time to healthcare institutions, density of primary healthcare institutions, and healthcare personnel distribution was proposed and was found stronger by the stakeholders that were participating in the pilot study. And the agreement upon the mitigation strategies that were implemented in the past, they were not deemed as successful, and most of the stakeholders did not agree upon the station that mitigation strategies were implemented. Past initiatives that were agreed upon were referring to allowances for young professionals to practice in rural areas, salary increases for the medical personnel, preferential mortgage rates, and of course, improvement in infrastructure and quality of life, factors that we've touched upon in the past. And although those measures have positive impacts, significant salary gaps with other European Union health systems, including neighboring country of Romania, remained. And this wage discrepancy increased the risk of medical personnel migrating, exacerbating the overall threat of medical desertification in the Republic of Moldova's health system. And that can be easily seen as Romania is a source country for European West countries, while Republic of Moldova is a source country for Romania due to those wage differences. And in general, in Republic of Moldova, the medical deserts are always a matter of not only medical, but also social aspects. The population from the rural and remote areas requires not only medical care, but more of a health and care approach from the authorities, especially for the elderly population. Because in any case, if you are old and you are admitted to the hospital with a disease at the end of that admission, when you are discharged, how are you going to reach your home? Are you going to reach a home that you have to make a fire to heat yourself, or will you go home to a cold house where you're going to exacerbate your previous health conditions? Do you have social connections that are valuable and provide value in your life and make you feel safe and protected? Or do you go home to be alone and exacerbating more your disease?
Excuse me, Monica, we're running out of time. Could you please
I will go faster,
accelerate a
yes.
little? Thank you.
Yes.
Sorry.
And now, no worries. As you see, as I've told you, we had almost 2 years of work on this. So we've put a lot of work and effort into that. We had 200 pages, almost more than 200 pages of the final report. So we have a lot of information to share with you. Now about Romania. We had 2 surveys and 1 qualitative consensus meeting with 19 participants, and then 15 and 8 in the qualitative consensus meeting. And as per the definition that has been agreed upon, medical deserts refer to several situations or areas where people have difficulty in accessing care, long waiting times, insufficient human resources, difficulties registering on the doctor's list, or long distances to the hospital. And some of the future efforts that necessitate active involvement from both healthcare and providers and policymakers. We had additionally, the journey to address medical deserts is ongoing, but the development and implementation of the policies is in a targeted way should be taken into consideration. We should address medical desert in Romania through a strategy that takes into account all the potential solutions for mitigation highlighted, together with raising awareness and fostering a collaborative approach involving stakeholders in the decision-making process. And we have to here I have to mention that no proper mitigation solution were implemented in the past. So salary simulatives were implemented and so on, but no something that was specifically targeted in medical desert. And we have several mitigation strategies here: the holistic approach to tailor solutions specifically for rural areas, to incentivize rural practices, to make sure that we're investing in prevention, to digitalize some of the services, to make sure that the communities are involved, and to have transparency in all the services that we are delivering, to have continuous monitorization and adaptation, to have strategic residency programs that is very important, and for advocacy for increasing funding. And of course, evidence-based decision-making and public-private collaboration, together with community education and long-term commitment, because targeting and focusing on medical deserts is not a fast-track solution. It requires a long-term commitment. As for the recommendations to mitigate a medical desert, we have 6 solutions, and I will start with increasing the number of practicing doctors. We can do this by encouraging the job retirement accumulation to allow doctors to continue working past retirement, to recruit foreign trained doctors, to improve the geographical distribution of their geographical distribution, to provide financial assistance for transport, accommodation, and practice, to implement zoning regulations and financial incentives for healthcare professionals like nurses, physiotherapists, speech therapists, dentists, midwives, and so on. And then Another solution is to expand the scope and role of professionals by increasing interprofessional cooperation, skill mix, and task shifting to support advanced nurse practices and to create new roles like medical assistant to support the primary care workforce. Then we have another solution that is for targeting the financial aspect. So financial incentives for working in specific areas that are deserted to reorganize primary care delivery, because most of the countries had an issue with primary care not being sufficiently utilized and tertiary care being too much utilized. Then we have to take national measures. We have to think at a national level, taking into consideration, of course, the regional and local level. We have to think national and to implement locally. And of course, utilizing e-health services for areas that are very secluded and for which we can deliver telehealth and telemonitoring services. Okay, and as per our conclusions, as per our explorations, all the work, the pilot study recognized that the inherent complexity of mitigating medical deserts, acknowledge the challenging terrain of policymakers and stakeholders that are navigating and highlighted ongoing initiatives, programs, financial supports, and regulations in motions. And in synthesizing the insights gleaned from the attached document, the conclusions, and all the work that we've seen until now, we have shedded light on the complexities surrounding the identification and mitigation of medical deserts. And we have to think that the foundation of any efficient intervention lies in the accuracy and reliability of data. And we have highlighted, I believe, quite well the critical importance of data quality, emphasizing the need for a nuanced understanding derived from multiple statistic databases. The presence of discrepancies between datasets underscores the need for triangulation, recognizing that a holistic view arises from the convergence of diverse data sources. And of course, we have diverse landscapes of the countries under the study, and that made the identification of medical deserts a challenge. And navigating the intricate landscape of information dissemination and stakeholder navigating the intricate landscape of information dissemination, stakeholders heavily relied on professional challenges, as we've mentioned earlier. So we have to think, how do we communicate with those delivering our health services? How are we making them aware of everything that is happening? This highlights the imperative for improved communication strategies to bridge this information divide. And then we need the extension of primary healthcare services. This would be a strategic move that is designed to significantly enhance the care efficiency and quality, addressing the root cause of some of the medical deserts that we have identified, as most countries had problems in rural areas. And of course, various initiatives, programs, and financial supports and regulations have been set in motion to mitigate medical deserts, and we are recognizing the intricacies of that task, affirming that the transformative actions require time to yield results and success in the end. And the trajectory from deserted areas to well-served regions is an evolving narrative which necessitates persistence, collaboration, and continuous adaptation to foster positive changes in our healthcare. And of course, we have to think about, I would say, the 5 C's. We have to think about our communities to make sure that we're involving them, we are listening to them, and we are making sure that we are trying to serve them. Then we have collaboration, because as you've seen, it is not sufficient that we have the healthcare system is well put in place if the roads, if no social options and leisure activities are available in that areas, people will not want to go there. So we are needing collaboration, and also collaboration between fields, both medical specialties and so on. And we need communication. We need to make sure that the people that we have there are communicating and that we don't have any communication gaps and everyone is aware of everything that they need to know. This was a very rich in information. I'm quite sure that it was the wealth of information can be quite hard to carry right now, but I'm very happy to respond to all your questions. Once again, in the beginning when we started the pilot studies, I was quite excited to see what the results are. We've seen that we have a lot of differences among countries in terms of medical deserts, but we have a lot of similarities. And we are only started working on medical deserts, so we are very much looking forward to the next steps. And with that, I want to thank you and to give the word back to Stella. Thank you.
Thank you, Monica. Thank you for this overview of the preliminary results of the pilot studies. I can well imagine how hard it was to sum up years of work in a presentation. Sorry, with the participant that we are a little bit beyond the schedule. I will give the floor to Corinne Hillopen, health advocate at VEMOS and project lead of AHEAD and other EU co-funded projects dealing with medical deserts. AHEAD is in a way an older brother of OASES as it finished in May last year. Corinne, thank you very much for accepting our invitation and for being here today. I would like to ask you, what are your reactions to Monica's presentation? AHEAD also dealt with medical deserts. You also carried out a consensus building exercise. Some countries were covered by both projects, not all of them. So you might have found some similarities, confirmation, also some differences, maybe if not necessarily contrasting, maybe complementing. And so what do you think of these preliminary results?
Yes, thank you, Stella and Monica, of course. Can you hear me okay? Okay, thank you so much. Yeah, it was indeed a very rich presentation and very recognizable because, yeah, indeed, some of the countries are overlapping. AHEAD which is an acronym actually for Action for Health and Equity Addressing Medical Deserts. Finished last year. We worked in 5 countries, including the Netherlands, Italy, Romania, Serbia, and Moldova. So indeed overlapping countries. And there are indeed lots of similarities and differences. And I want to amplify a couple of Monica's messages and complement them also with a few AHEAD findings and experiences. And I'll try to be brief because I know we are running out of time. I try to be brief and is still meaningful. And I want to focus on 3 different things. Not so much the content of the mitigation strategies that have been presented, but on the how to get to these mitigation strategies and policies. And they are concentrated in 3 categories, so to speak. It's on the level of policy interventions required, on stakeholders, and on data. So if you talk about the level of policy interventions that is required, you have to remember that medical deserts are a very localized phenomenon. And this phenomenon is a result of a complex interplay of different kinds of policies from different sectors and at different levels again. So the solutions also lay at the different levels of policy making. I mean, you have national policies that say something or that have influence on how many graduates there are, nursing, doctors, pharmacists, etc. But you also have more local policies when it comes to transportation issues, for example, or these, or who gets to settle where or buy property, real estate where, which may be important if you want to set up a new practice in a medical desert area or a deserted area. So you really have to understand very well the complex interplay between local level policies and national level policies and anything in between, actually. So about the stakeholders, we've heard this word a lot also in Monica's presentation, and that is always, of course, in all the projects in this cluster was a key issue to unravel. We also implemented a consensus building methodology, as you mentioned. We did it slightly different than OASES. we identified in all the 5 countries 1 or 2, sometimes 3 case study areas, which were identified as medical deserts. And we started holding consensus building sessions there, discussion sessions live that could be from 8 persons up till 15 persons, sometimes even more, sometimes even less also. And in these sessions, you really try to understand each other's interests and perspectives and responsibilities, also mandate, to understand, you know, everybody's stake in the issue, because everybody in all the stakeholders are at somehow affected by this phenomenon. And you want the people on board who are willing to engage in that is such an exercise, but also who we expect to also contribute to the solution. So no free riders, but you need to throw your net out wide. We had aldermen, mayors, municipal council people, health facility managers, patients organizations, people representing the interests of the elderly people, for example. You have to throw a wide net and see who is at the table and who will work with you on solving the issue locally. Then the data, Monica mentioned it, there's always an issue with data. They are incomplete, or they're old, or they are not available at the desired detailed disaggregated level, so the local level. So we need to keep advocating for better data. But I would like to add 2 things on data. Not having the desired data is not an excuse to do nothing and just lean back. Most people know enough to understand what needs to be done. And the second thing about data is it's not just the info that you need to initiate policy action. It's not just data that you find in statistical bureaus or in health management information systems or other official sources. It's also information that resides within people, the people who are affected, whether they are living in the medical desert or working there or otherwise involved and affected. So you need to get their perspectives, their take on things, their expertise, their lived experience, and get that also into the equation to get to effective policy action. I'll leave it at that for now. There's lots more to say, but maybe we can still take some time to take audience questions. I saw already a couple of them coming in. Thank you.
Thank you. Thank you very much, Corinne. Thank you very much for your presentation and for widening, let's say, the perspective on the topic of medical desert. We have also pasted the link to the AHEAD project website in case anyone wants to learn more about the activities they have been carrying out. And yes, we have received quite a lot of questions from the audience. Monica has already replied to some of them. I will ask my colleagues if there is any question that is still awaiting a reply. Maybe I will share my screen. Okay, this is not a very visible color, let's say. So Julia, okay, Julia received an answer. So maybe the question from Esther. Esther, she asked how many of the pilot countries mentioned or implemented task shifting as a mitigation strategy. And
Stella, if I may,
Yeah.
I did not get a response to Esther because I was just going over the final report just to make sure that I counted correctly the number
Okay.
of countries, and I've seen these mentioned 4 times in the report, out of which 1 was in the final part. So we have 3 mentions from countries, and I would say, but that would be from 2 countries. So 4
Okay.
more mentions in total, but 2 countries.
Okay. Okay. Of course, when the whole report will be published, you will be able to have more details about, in what terms those were task shifting was mentioned and implemented. And then there is a question from Nora Di Lorenzo, who is wondering whether you are considering to increase the data available on other healthcare professionals, formal and non-formal staffing, as they are commonly forgotten.
Yes, that is a very good question. And this discussion we also had with other points with WHO, because in their when they're looking at human resources, oftentimes it is quite limited. Of course, the good thing would be to include all healthcare professionals, as we've mentioned in our report. We were discussing about also speech therapists, recovery, and so on. So we are trying to go as further as possible, and as Corinne said, to throw a net as wide as possible. But of course, we can only make recommendations and not have a real impact on what the policymakers are deciding to do, unfortunately.
Thank you, Monica. Corinne, what about you? Did the task shifting emerge in the AHEAD project, and what about this consideration of increasing data available of the healthcare professional? Was it covered in the project? Do you have any other perspective? Yeah.
No, absolutely. I can only echo what Monica is saying. It did come up, I think, in 3 of our countries. That task shifting could be it could be one of the solutions, but also we need to be careful that, because what happens a lot is that tasks are sort of thrown at nurses, from the doctors to the nurses, which will then also increase the work burden of the workload of nurses. And you have to be very careful of that, because the nurses, as we know, are actually the backbone, the main pillar of primary health care. So it's one of the solutions, or part solution, but we need to be very careful on how to implement that. Yeah. Thank you.
Thank you very much, Corinne. I think we have no other questions, but of course, we have shared our contact details, and we can share them again. So if you have any other question you would like to ask to us, or and of course, if you want to look at the whole report of the pilot studies with all the details about the pilot studies, we expect it to be soon available on the OASES project. You see the link on the chat box. So I thank you very much for attending and participating to this webinar. I invite the policy board members who are online to please stay online for further discussion. We are starting briefly. And for the others and everyone, I hope you all found the webinar to be informative and interesting. As anticipated, the recording will be made available on the OASES project website. So if you want to hear more on health workforce, please find in the chat box the links. And also, please note that on the 26th of January, there will be an online conference on health workforce challenges and how to deal with them. And based on the recommendations formulated by this project, AHEAD project, and other projects, EU-funded projects dealing with health workforce. You also can find that link in the chat box in case you want to learn more about this conference, this event. So I thank you very much again for your interest and attention, and goodbye.